Dr. Timothy Henry, Director of Research at the Minneapolis Heart Institute Foundation, is an interventional cardiologist at the Minneapolis Heart Institute, Abbott Northwestern Hospital. He's also a professor of medicine at the University of Minnesota School of Medicine. His research interests include interventional cardiology, acute myocardial infarction, and novel therapies including stem cell and gene therapy for patients who are not candidates for standard revascularization techniques. The topic today is autologous stem cell therapy for the treatment of refractory angina. So please help us welcome Dr. Timothy Henry. Thanks for being here.
Thank you very much. I'm actually delighted to be here, and hopefully people enjoy this exhibit. It's fascinating to me. What I'd like to do today is talk a little bit about patient population refractory angina. I think is a little bit misunderstood, and really I think it's an opportunity for us to improve our practices, and then talk about the role of cell therapy in these patients. So as a disclosure, I do research with Baxter, Angioblast, and Astrum, so we're involved in the clinical trials, but I don't own anything. So if you look at these patients, really the number of these patients has increased as the mortality, overall coronary artery disease mortality decrease, and that population ages. So it's estimated that there's more than 12 million patients in the United States that have angina. To give you an example, in the COURAGE trial of medical therapy of PCI versus medical therapy, almost 50% of the patients in medical therapy arm had ongoing angina at 1 year. And almost 40% in the PCI arm still had angina. So there's a lot of angina out there that we're really undertreating. If you look at it, the estimates have been 10 to 15% of patients undergoing a cardiac cath have myocardial ischemia. That's not ideal for bypass or angioplasty. And these are people with chronic total occlusions, diffuse disease, degenerated varografts, and you know them in your practice. Now, it's been said that these no-option patients or refractory angina actually have high morbidity and mortality, and we'll talk about that. Oops, wrong way. So when you look at these, and I think one of the issues is, and why it's complicated, is if you take these patients, they're called no-option patients, refractory angina, advanced coronary disease, non-revascularizable refractory ischemia. You can't look in any database and actually get outcomes. So you can't, they're not coded with Medicare or et cetera. You can't really find, it's not easy to look at outcomes. And then the problem is, it's really three things. It's a combination of symptoms. I gotta fix this. It's a combination of symptoms, coronary anatomy, and myocardial perfusion. And people actually use various things to describe the patient population. When really what you're looking for is the classic patient is one that has all three, but there's a lot of variations of these patients. Now, the ESC task force, it's interesting because the ACC guidelines actually don't really even deal with this problem. In a 200-page document, there's only 3 paragraphs about refractory angina. The ESC, on the other hand, actually had a specific task force, and what we're talking about is the patients who have angina the patients who have angina with coronary disease that's not controlled by medical therapy or revascularization. Now, how many of those people are out there? Well, it's not really known, and I think the other thing about the European Task Force is that they said there's an urgent need to clarify the epidemiology of this condition. And we'll talk about where we've come since this task force. Now, the data that people looked at that said was from Cleveland Clinic. It was about 15 years ago. And it was looking at 500 consecutive patients, 59 of which had this refractory angina. Severe disease, symptoms, not candidates for revascularization. And when you looked at that, the mortality rate in that group of patients was 17%, 25% at 1 year had myocardial infarction, 128% had rehospitalization. So this is clearly a group of patients that have high resource utilization. Now, what we did is we looked, is that still the number, and what's happened since that time? So we wanted to have a 3-year period of time, so we took 500 consecutive patients at our institution in 2005, and we divided them into normal coronaries, mild coronary disease, patients who got complete revascularization, partial revascularization, and then these two groups right here were really no options on medical therapy already or medical are not candidates for revascularization, but you could improve their medical therapy. So if you look at that, that's 16% of the patients actually are not candidates for revascularization. So this is your cath lab too. These patients are out there. But what typically happens when they have a positive stress test, angina, we do an angiogram, we say, well, there's nothing we can fix, and then they go home, and the internist says, well, the cardiologist can't do anything. And then these patients have more angina, they get depressed, they gain weight, they can't exercise, and they're in this downward cycle. So we believe that there's a lot of these patients out there that really are markedly undertreated. And the total of 29% had incomplete revascularization. We then looked at the mortality, and indeed the patients with partial revascularization did have higher mortality. But it's not anywhere near 17%. In fact, in this group population, it was about 15% at 3 years, so about 5% per year. Now, we also have a clinic, so we have a specific clinic now that we have 1,400 of these patients that we actually follow long term. And who are they? First of all, it's a very well-treated patient population. Almost all the patients are on antiplatelet therapy, statins, ACE inhibitors, beta blockers. Less than 10% still smoke. But they also have had severe coronary disease for a long time. So a high percentage are diabetics, high percentage actually have heart failure, 75% plus have had previous bypass surgery, angioplasty, or myocardial infarction. Now, when we looked at these and 5-year follow-up, the mortality was 17%. So that's about 3% per year. And 1/3 of it was actually non-cardiovascular. And when we look at this, and this is actually now of the 1,400 patients followed long term, and I'll tell you this is a very accurate curve, because in the last 2 years when we actually predicted how many patients would die, we were within 1 patient of predicting. So when you look at that, it's about 3% per year, and 1/3 is non-cardiovascular. So these patients actually don't have high mortality, but they have a really impaired quality of life. So when you look at it and you design trials for that, you need to take that into account. If you're trying to improve mortality, you're not going to do it because it's so low, and we'll show you some insights into that. So what we did is when we developed this program, our goal was to sort of improve the quality of care for this unique and growing subset of patients, to define the long-term outcome, natural history, and predictors of adverse outcome, and more importantly, to provide unique treatment options, both currently available as well as novel research approaches. So why do we call it the OPTIMIST clinic? How many of you would send your mother 6 hours to go to the no option clinic? So we decided we'd have a name that actually would get people to come. And what we do is when you come, we actually get all of people's old records. We make sure that you're on optimal medical therapy. And optimal medical therapy means your LDL is controlled. It means you're on the ideal anti-anginal. It means that you've had the revascularization that is appropriate for you. And then if all those things are in order, then we provide a number of different options: angiogenesis, ECP, neurostimulation, ranolazine, L-arginine, TMR, and then novel interventional techniques, so advanced CTO work and ultrasonic therapy, etc. So what I think is you need a comprehensive approach to this problem. What we're going to do today is specifically talk about the role of cell therapy in these groups of patients. And this is the group that we couldn't do it without them, so we really need it. So can we really grow new blood vessels, or can we make blood flow, improved myocardial perfusion? The answer is, if you look in preclinical models, any model you want to look at, protein therapy, gene therapy, and cell therapy, you clearly can. Absolutely crystal clear over and over again, you can improve myocardial perfusion. And you can improve perfusion in multiple different models. If you look at phase 1 unblinded trials, everything has also worked. So the phase 1 trials are always positive. And we're going to come back and talk to you about that. The problem is, what about placebo-controlled trials? And if you look down here in cell therapy, in this patient population of refractory ischemia, there's about 300 patients, and the FOCUS trial was just presented this morning, so that would make approximately 400 patients that have been in randomized placebo-controlled trials. So the data is limited. Now, important aspect of these patients is there's a significant placebo effect. So this is just the placebo group of the randomized placebo-controlled trials. And in the placebo group, what you'll know here is I don't think that pointer works. But you'll note in that 4 to 6 months, you can expect nearly 1 minute improvement in exercise time in the placebo group. So that's the problem of doing unblinded trials. If you don't have a good placebo group, you really are not sure what's going to happen. Now, there's really 4 trials that I'm going to talk a little bit about today. This is a Dutch trial that was published in JAMA a couple years ago. 50 patients with refractory angina, normal ejection fractions, randomized to intramyocardial injection of bone marrow mononuclear cells versus placebo, and with the follow-up. So a very small trial, but in that trial, if you looked at myocardial ischemia by SPECT, there was improvement. There was also some improvement in the placebo group, but it was statistically significant, but I would say modest. The ejection fraction also slightly improved, but again, if you look, both of these groups had ejection fractions that were near 60%. So you aren't going to expect to improve ejection fraction someone who has a normal ejection fraction to start with. The other thing is, if you look at both angina class and quality of life, the trend is in the right direction. So in this patient with refractory ischemia, in a small trial, blinded, there was some support for that. Now, importantly, the FOCUS trial, the FOCUS HF trial, which was published in American Heart Journal, this is the same group of patient population, but with decreased LV function. But they were required to have reversible ischemia. Now, this is a small trial, only 30 patients, but I think there's important insights to the trial, and we'll talk about that. The key thing that we did is we did a lot of work in terms of Emerson Perrin and Jim Willerson were the principal investigators for this trial. The key thing is we did an extensive evaluation of the cell function, and we followed that up with this morning's talk, and you can see. So we looked at a variety of different ways of do these cells work. So are these functional cells? Because what we know is that as you get older, both the number of your stem cells, a variety of different stem cells, decrease, as well as the potency. So there's clearly some age-related and risk factor-related issues, and cells are different. Overall in the trial, there was no difference in terms of the improvement in the control patients versus treatment in symptoms. There was no differences in MVO2 or echo. There was some improvement in SPECT reversibility. Importantly, if you look at the area that was injected, there was improvement both by SPECT and MRI in a small sub-study. But this is too small, and I really wouldn't. The important part about this was this. These are the bone marrow and the cell function in terms of the mesenchymal colony-forming units for the patients in the trial. And you look at the significant heterogeneity. There's only 2 of the patients that actually had cell growth characteristics that would be in a normal range. So if you look at this patients, if you take subject number 6 or 9 or 11, you can see those cells are really not very functional at all. And in fact, did that matter when we looked at this? And this again shows the significant heterogeneity in terms of growth, where you have patients that really have almost no the cells are not very functional at all. And you look at it, in fact, in particular, there was a difference in the colony-forming unit for mesenchymal cells in elderly patients. It was significantly decreased. And when you looked at it, did it matter from a physiologic significance? It did. If you were over 60, there was no differences in your MVO2. If you were under 60, in fact, there was this trend towards improvement. So again, not the take-home point, and the results that Emerson actually presented the results this morning in late-breaking trials. Overall, the endpoint was no significant differences in MVO2 or in systolic volume, but there was an improvement overall in ejection fraction. Importantly, the patients who had functional cells did better than the patients that didn't have functional cells. So I think it reconfirms this. And what does it show me? It shows me there is some physiological significance to the cells, but it shows me we can clearly do it better. And I think one of the things is sort of the next generation where you actually take allogeneic cells, so allogeneic mesenchymal cells, or if you take cardiac-derived cells, sort of the next 2 steps of generations of cell therapy, I would hope that that means that we'll be able to actually do it better. And we'll show you an example of that. So this is from the CCTRN. Now the next thing that I'll talk to you about is really, this is adipose-derived cells, a small trial that was done that's done by Satori. They do liposuction, take out the adipose-derived cells, and randomized patients, again, with ischemic, reversible ischemia. And what they saw in this trial, there was this improvement in symptoms, again, a very small trial. But the results of this trial may actually lead to improvement CE mark in Europe, which is interesting. And there was improvement in terms of how many METs you're able to do on a stress test, as well as in your MVO2 in this small trial. So again, some supportive evidence for this patient population. But the best data actually comes with CD34 positive cells, and that's what we're going to finish talking about and show the data with CD34 positive cells. This actually comes from Douglas Sordo. A phase 1 trial was really based on good preclinical data. Remember now, our goal for these patients is to improve blood supply. Myocardial, both epicardial and microvascular perfusion. And when you looked at capillary density in a rat model, patients' CD34 positive cells were more potent than bone marrow mononuclear cells. This was followed up by a porcine model, and if you can see with an amyloid constrictor into the ischemic zone. The pointer doesn't work very well, but in that ischemic zone is where we injected. And at follow-up at 4 weeks, there was a significant improvement in the ischemic zone. And if you can see, the ischemic area by NOGA was significantly improved. So that was encouraging and led to the phase 1 trial. We use a NOGA catheter, so we go across the aortic valve and we inject into the ischemic zone. The design of these trials are class 3 and class 4 angina who are on optimal medical therapy, who are not candidates for revascularization. All right, and it's a very consistent group who have failed therapy and are actually exercise in the first trial is between 1 and 6 minutes. We give GCSF for 5 days, which increases your bone marrow production of circulating CD34 positive cells and other stem cells as well. And we do apheresis to take out the CD34 positive cells and inject them into the ischemic zone. When we did this in the phase 1, in the green is the cell-treated patients, there was a reduction in anginal episodes compared to placebo. If you looked at, there was a reduction in the use of nitroglycerin compared to placebo. There was a crossover at 6 months, so we did not have a placebo at 1 year. And there was the percentage of patients with a greater than 2-class improvement. More importantly, you'll notice over time it continued to improve over time, and both trials have actually shown the same thing. This is an example of a patient in the trial, the voltage map on the left, the shortening map on the right. If you look at that, you can see where we injected into the red area of the ischemic zone. That was followed up, and this patient had a significant improvement in exercise time, the time when angina onset. In fact, if you look at 6 months, there was no angina at all on the treadmill. At the same time, there was an improvement in both the stress and the rest scans. So again, this is CD34. In particular, there are some particular responders, and we can talk about that a little. So that phase 1 trial led to, again, this was a double-blind, placebo-controlled trial, so it was a completely blinded trial. 167 patients, very similar trial design, low-dose cell therapy, placebo, or high-dose cell therapy. And I think this is a very important trial to know about called ACT34. It's published in Circ Research. The trial is not powered for endpoints, but in the trial, you'll notice there was a reduction in endpoints, and any way you look at it, all trended in the right direction. In particular, the death rates at 1 year were 5% in the control, no deaths at all in the cell-treated patients. So these are class 3 and class 4 angina, no-option patients. Again, confirms mortality is not the problem. There was a reduction in myocardial infarction, and there was a reduction in urgent revascularization. All of them are in the right direction, but it's not powered for that. What it was powered for was to look at angina. And you'll see on the left, I think importantly, the placebo group had a reduction of 9 episodes per week. So there was this expected placebo effect. On top of that, there was a significant reduction in both treated, but in particular in the low dose. And if you look, and secondly, in terms of exercise time, there was an expected minute improvement in exercise time. On top of that, there was over an additional minute. This is the only therapy that's ever shown a significant improvement in exercise time for patients with refractory angina. No other therapy's done that, including ACP. So I think that this is really positive results and really encouraging. And if you looked at the 24 months, again, close to statistically significant, much lower mortality in the treated patients than in the controls. All in the right direction, not what it was powered for, but certainly encouraging. The second thing is, if you look at angina counts at 24 months, it still was statistically significant reduction of angina in the treated groups. So I think it's importantly, and we're going to end with this now, this is the phase 3 trial, 400 patients, 200 treated, 100 in the active control, and 100 in medical control, which is after exhaustive work with the FDA, the design that we went with. So this trial is just beginning, and actually the first patient should be enrolled next month, and I think a very important trial. So just for the record, bypass didn't work, angioplasty didn't work, medical therapy didn't work, and tender loving care didn't work. So this is a challenging patient population, but they're still not available at the florist yet, but it's much closer after Act 34. And I will say that if this trial is positive, that the FDA has said that this will lead to approval of the first cell therapy for a cardiovascular disease. So we're excited about that trial. Thank you very much.
Fantastic. How about a nice thank you to Dr. Henry.